Good evening. Thank you, ladies and gentlemen, for coming on to this next installment in our uh, Lung Cancer Network Malaysia and National Cancer Society of Malaysia's joint session on lung cancer. We've just moved beyond November, which really was Lung Cancer Month, but as you know, this is a problem that hasn't quite gone away. And over the past couple of months, I think we've gone through the various stages and looked at all the kind of different segments or different parts of the journey for a lung cancer patient. And today, I think if it's not the most important, is perhaps one of the most important segments that we would like to discuss, and that's on the role of palliative care. And as much as it is a difficult subject to deal with, and especially in Asian societies such as ours, where sometimes it's the role of palliative care or the moment at which the patient actually reaches into the stage where they need to receive palliative care. It's always a decision that's not within the hands of the patient alone, and often there are family members, friends, so kind of greater group of people who are involved in the decision making. So it's a very complicated field with a lot of complicated issues surrounding it. So we've got someone who's here to untangle all these knots, hopefully, and make it really clear. And I'm also very pleased. What is this? That Dr. Karin Koo, who is a palliative care physician and a consultant with Sunway Medical Center. Dr. Karin is also a member of Lung Cancer Network Malaysia. So, good evening, Doctor. Thank you very much for being able to join us today. Um, so, you want to say hi as well, Doctor?
Yeah,
Sure.
good evening, Dr. Murali, and to all the viewers who are able to join us today. First of all, thank you so much for inviting me. I'm delighted to be able to share a little bit about palliative care.
Right. Thank you so much, Doctor. And again, really, thank you so much for coming out this evening and joining us and kind of putting out these very important insights for everyone to be able to share on this aspect of a patient's journey in managing their cancer. So, really, for those who are joining us, you all remember this is always now has become a post-makan session. So I'm hoping you all have finished dinner and are sitting down, having your half or quarter cup of teh tarik or whatever it is that you're having, a dessert or ice cream, and like cozily sitting down and kind of catching up with the session. So we speak here to speak about palliative care, really. And actually, even the term is taboo for many people, for a lot of people. And I think one of the biggest issues surrounding palliative care is the idea for the individual or a lot of people in Malaysia that this means the end.
Yeah,
You know,
absolutely.
yeah. So really, Dr. Kenny, what is your perspective on this?
I think what you said is really true. Oftentimes, when people hear the word palliative care, they often associate it with death and dying and of giving up. But I think first and foremost, I wanted to share what is actually palliative care.
Right.
And this is a definition by WHO actually. Uh, WHO defines palliative care as actually an approach that improves the quality of life. So the focus here is on quality of life of the patients as well as their families, those who are facing a life-threatening illness. How do you improve that quality of life is actually by focusing on reducing suffering. Suffering may come by means of pain or other symptoms, psychological distress, social isolation,
Right.
spiritual distress as well. So palliative care is really an approach that focuses on relieving, first of all, identifying,
Mhm.
managing, and relieving these symptoms with the eventual goal of improving the quality of life. So if I may share, actually,
Please do, Doctor.
So the way I see it, actually, palliative care really focuses on three things. First of all, really aggressive symptom control, symptoms such as pain, breathlessness, nausea, but at the same time providing some degree of psychosocial and spiritual support to the patient as well as the family. And to some degree, we also try to help patients prepare about what's coming in the future, whenever it may be. We prepare the family, talking about what would be the expected care needs eventually. But it is actually a targeted approach at these different components. The way I look at it is actually palliative care is a whole person care, promotes quality of life, treats the whole person, supports the family. It's an actual extra layer of support for all of them. And if you think about it, it's not so much about dying, isn't it? It's actually affirming life, helping the patients to live as well as possible in whatever time that they may have. Um, Now, I want to share also why people might think about palliative care only at the end. I think traditionally the old concept was that doctors would only refer to palliative care providers when there's no longer any curative or disease-modifying treatment. If they have already exhausted all sorts of treatment, for example, radiotherapy and chemotherapy, patients are really ill and weak, and that was the time they would actually refer a patient to palliative care. As you can imagine, that doesn't leave us very much time, actually. That also means that the patients are also very close to death. And I think that kind of perpetuates the whole understanding that palliative care is only about those who are at the terminal stage.
Right.
However, there's been a newer concept, the integrated model of palliative care, and this concept has been around for at least a decade, where palliative care is involved at the start, at the diagnosis of an advanced illness. And we work alongside the primary care providers. So if we're talking about cancer, we're talking about the oncologists. So perhaps at the start, when patients don't have too many problems, don't have too much symptoms, our role may not be that large, but at least we are there helping to walk with the patient along the journey, even as they go through treatments. And sometimes patient, I will share later in my slides, but oftentimes patient will have pain, either from the cancer or sometimes from the treatment. Example like mucositis related to the radiotherapy or other side effects from the chemotherapy that may limit their ability to even continue with the treatments. So if you have aggressive symptom management and we are able to actually reduce all these problems like pain, it also enables the patient to go ahead and complete their treatment without interruption. I think a common scenario that we will face would be a patient who has metastatic cancer and cancer has gone down to the spine, and they may have some pressure on their spinal cord causing them pain when they're lying back. So commonly with cancer having gone to the spine, the oncologist would want to give some radiotherapy. But patients like this, they have a lot of pain when they lay back. And so I think a lot of times radiotherapy may be postponed for that reason. So when we see the patients, we aggressively manage pain. We probably, most of the time, we will need to use medicines like morphine to control the pain and get them to be more comfortable. And once they're able to lie back flat, they are able to actually undergo the prescribed radiotherapy treatment by the oncologist. And I think it's a win-win scenario because on one hand, we're able to improve their quality of life, and at the other end of it, they are able to actually go along with the prescribed treatments. And for some patients, disease may remain well controlled, but for others, it may very well progress. And then the role of the chemotherapy, radiotherapy, other disease-modifying treatment may become smaller. And by that time, our role as a palliative care provider would actually get larger until to a point when death happens. And the role of the palliative care doctor doesn't end then, because we actually provide bereavement service, bereavement support to the family members. So the way I see it, I think palliative care is about walking with patients on their journey. It's not really just focused at the end of life.
Right. And actually, I think just to kind of nail that point in, Doctor. I think it would be lovely if we left up that little box from, I think, the earlier slide where it was a square. And I think for a lot of people, the understanding is this, as right at the beginning, is what I was telling you, the idea that referring to a palliative care physician means that I have now been unable to do any other further treatment. And I think the first insight that we are all getting from you today is, look, this is not true anymore, right? Because the idea, and that's exactly, I think me and Dr. Karen were chatting slightly earlier about this, the reason behind a lot of our thinking as to why we're actually scared to go and seek the palliative care physicians or bring in the palliative care physicians, because it's a psychological thought that we think that we have now failed, in terms of the patient feels that they have failed. The family feels that, look, that means we have given up hope, there's nothing else to do, let's call in the palliative care. So it's almost like the thought process about calling in palliative care physicians is right at the very end. And I think that's one of the problems you see in quite a bit of your patients, right, doctor? They come to you
Absolutely.
too ill.
Yeah.
Right, and why is that difficult, doctor? What's the problem when you actually get patients coming to you in these stages, when, like, okay, they've everything has been done, now nothing can be done anymore, now only I come to the palliative care physician? How does this change things?
Um, I think if you look at it from a few angles, why does this happen?
Mhm.
If you look at the doctor's perspective, sometimes I would say not all the time, but sometimes there are doctors who feel that by calling the palliative care doctor, by referring a patient to palliative care, it means that they have failed. I
Right.
think medical school is all about teaching you what to do about treating something, a condition, a disease. It doesn't talk about what to do when treatments are not working according to plan.
Mhm.
So perhaps some of the doctors, probably the older generation doctors, why do I say that? Is because palliative care is not a concept that was taught in medical school many years ago. And so many more senior doctors may not be really comfortable with the idea of getting palliative care involved. They're still very much of the mindset that I should only call for palliative care when there's nothing else that I can offer.
Right. Right.
But I think recently, medical schools have been included in terms of palliative care advocacy. More medical schools have actually incorporated palliative care into their curriculum. So
Right.
the younger doctors are actually more comfortable with the idea of including palliative care early on, even as patients are still going through what we would say curative or disease modifying treatments. So that would be from the doctor's perspective why we're not included early on. And then from the patients and families' perspective, as what you correctly pointed out, people still associate palliative care with giving up when nothing else can be done. And if you look at this model, actually you can see it's a very abrupt transition
Mhm.
from oncology care to palliative care. And studies have shown that patients and families are really distressed. They feel abandoned by the oncologist when this happens.
Right.
So it's not a really good model to begin with. And I think at the end of the day, it also leaves patients, um, suffering, for lack of a
Mm.
better word, early on if their symptoms were not adequately controlled. If palliative care is involved only at the end, when the patient is dying, I think we may try to treat the symptoms there and then, but we've lost the chance, the opportunity to walk with them on their journey, helping to support them from the aspects of the psychosocial and spiritual components actually. So that's why I think we are actually looking at this newer concept. Even if I say it's newer, it's not all that new. As I say, it's been around for years.
Only doctors in Malaysia, 10 years, innovative really.
Sure. And as you can see in this graph, even after death, patient may have gone, but families will suffer the loss. And what we do is we provide bereavement support to the family members who are still grieving. And grief is normal. When somebody you love passes away, it is normal to be sad. It is normal to be constantly reminded, crying. But there are times when grief becomes abnormal, when it becomes abnormally prolonged, or when it limits your ability to function normally. For example, you are grieving so much that you are not able to concentrate, you're not able to get back to work. I spoke to a family member of a patient who passed today, and what struck me was that the thoughts of that final day kept playing in her mind so much so that she can't concentrate even while driving. So that is abnormal grief. And when we find cases like that, what we will do is we will get them linked to the correct channels. They need more support, more than even a palliative care service can provide. In these cases, probably a psychologist or a psychiatrist would be much more helpful.
Right.
So that bereavement support is important as well.
Yep. Yep. And also, and perhaps kind of to give also a lot more context to this in the Malaysian setting, is highlighting really why Dr. Karin is saying that, look, you need to bring the palliative care physician early on into the kind of the multidisciplinary management of the patient. This is simply because in Malaysia, for almost all our cancers, we are still diagnosing a majority of them in late stage. So,
Absolutely.
and I think one of the big problems with the traditional model is what you were showing us earlier. It's very progressive in the sense that if you diagnose a patient stage 1, stage 2 very early on, there's this long journey in which they may actually really, kind of largely focus on this idea that they can be treated, and they are looking at remission, cures, and all that. But realistically, as we start diagnosing our cancers more and more in advanced stages, and this is really true of lung cancer, where we diagnose, I think, about more than 90% of our cases in stage 3 or 4, you start to see why this model that Dr. Karin and other palliative care physicians are putting out means that from the onset, you need to bring in the palliative care physician, because we're looking at people starting up with a lot more symptoms, a lot more severe symptoms. And that's why they need really the palliative care physician to come in together with them. Dr. Karin, really just to curiously ask you, are a lot of the patients that you see patients that are coming to you like newly diagnosed, or are they patients who come to you right at the end, or is this a trend that's changing now?
Dr. Murali, I think it's a mixed bag. We do get referrals where patients are recently diagnosed with advanced cancer. And I think, especially if patients and family members themselves are asking to be referred to palliative, they get referred early. So patients are advocating for themselves. But sometimes we do get referrals where, they've been going through a lot of treatment for months, maybe even years. And we're only seeing them with, in a stage where, as a doctor looking at the patient, I might estimate patient may only have days or a couple of weeks to live.
Right.
So it's a mixed bag, and sometimes it's also related to the oncologists involved. Some oncologists are more comfortable involving the palliative care doctor earlier, and some try not to.
Right, right. So, and really, as this is a public session, ladies and gentlemen, the message that we are trying to put out today is one of self-advocacy, and perhaps I mean, I'm such a pessimist that everyone who knows me, when I tell you that it's not about people, whether you're a patient or not, it's whether you have got cancer or you haven't got cancer, and that's about it. And so this might really come in handy for you or family member in later stages, when you actually do end up, unfortunately, kind of picking up cancer. Is probably kind of very critical for you to consider bringing in the palliative care physician for all these reasons that Dr. Karin was telling you about. So it's really about now increasingly becoming a multidisciplinary management, and that actually gives so much of benefits to patients. Dr. Karin, maybe would it be kind of illustrative if maybe you shared with us some of like really an experience of uh, how like you actually holistically manage to kind of give this kind of needed care to a patient?
Okay, I think if you're talking about holistic care, as mentioned earlier, I think by WHO definition as well, in palliative care, we focus not just on the physical, but
Exactly.
also the psychological, the spiritual, the social aspects. I'll give you an example. A patient, a woman, may have breast cancer, advanced stage breast cancer, may have had mastectomy, but now recurrence of the cancer over the chest with a fungating mass, a wound, a tumor that is growing outward. Oftentimes, there may be associated with an unpleasant smell. So, having the cancer over the chest may cause physical pain. And for that, we have really good medicines like morphine to control that. But beyond that, you need to understand as a woman, the breast is part of being a woman. So there may be some other aspects to this. There may be some psychological distress. She may feel that, she's not whole as a woman.
Right.
It's not true, but, this may be what people may feel.
Exactly.
And she may have little children who may not fully understand and who are reluctant to come near her because of the smell. So that can cause a lot of psychological distress, depression, anxiety. There may be a spiritual side to that as well. Say a person who, has been a good person all her life, has been
Right.
volunteering, caring for the unfortunate, has never spoken ill of anybody, and gets afflicted with cancer at a young age. And there may be distress about, why is this happening to me? Did I do something wrong? Is this a punishment from God? And all this would feed into thoughts and, aside from leading her into depression, may also affect her perception of pain. And so if no one's going to actually explore and talk to her and help her sort through some of these things, she may end up feeling very alone, very isolated. So palliative care, for us, when we do palliative care, it's not a 5-minute visit with the patient. Oftentimes, my first visit with a patient may be more than an hour, trying to get to know the person, not just treating the disease, but trying to get to know the person behind the disease. How has this illness affected her? Of course, we are going to focus to treat her pain, but then there's also non-physical aspects of pain that is not easily eased with just morphine. And oftentimes having a listening ear, being there, supporting them actually does help to ease some of the non-physical pain as well. Why do I say that? Just giving you a very simple example. I don't know, Dr. Murali, do you have do you struggle with back pain sometimes from standing, working a long day? A lot of us on our feet, usually by the time we go back after a difficult day, we have a little bit of back pain. Have you had any experience like that?
Sure.
Yes.
Yep.
Okay. So for us, when we trying to assess pain, we get patients to give a pain score, 1 to 10, because I can't feel the pain. I don't know how severe it is. So we try to get an estimation. So if you say you have a moderate pain, back pain of let's say 5/10 after a hard day at work, and you come home and you were supposed to get some groceries and you forgot, and you came home and your wife asks you about it, and you get into a heated argument about forgot to pick up the milk or whatnot, and suddenly your back pain may shoot up to a 7 or 8.
Yep.
Right?
But really, in this case, no, I'm joking. I said in this case, it'll be back pain caused by my wife beating me. But yeah, sure.
Okay, sure. But that kind of it gives you an example how the psychology can affect your physical experience of pain. But then say you have a little girl, a cute little girl who runs up to you and say, "Daddy, Daddy, I love you, I've missed you." And then suddenly the pain from an 8 comes down to a 4, maybe. So that is, that is what we experience even as a normal individual going through our normal days. So what you can only imagine what a cancer patient may actually feel. The physical pain there is there, no doubt, but then there's also the other components. So, sometimes just sitting down, talking to them, giving them space to express themselves actually does wonders for their pain. because the other thing, it could be a Malaysian culture, it could be an Asian thing. Oftentimes when patients may want to share about their illness experience or about the cancer or about thoughts of dying, there's a lot of worries. Family would tell them, no, don't talk about that. Don't be so negative. You must think positive. And I know it's done out of love oftentimes, but it also dismisses their concerns and they don't have an outlet to actually express their worries.
Yeah, and I think that that's really an important avenue for people to come to. I'm going to kind of move a little bit, Doctor, and speak about this too often very confused terms in this landscape. When you talk about palliative care, then there's people who talk about end of life care, and then there's actually a lot of groups or organizations that actually are hospice organizations. So really, Doctor, this is the time to clear up the air about this. Is palliative care the same thing as hospice?
Okay. Thank you for asking that
Yeah.
question. And I think it's an often misunderstood one.
Yep.
So let me just share this next slide. I just want to explain about what the differences are, because I think anyone who has access to internet, you can Google, and Google will tell you that hospice care is a subset of palliative care. So palliative care is what I've mentioned earlier, focus on improving quality of life by managing symptoms or other problems associated with a life-threatening illness. And if you look through Google, you'll find links where they talk about hospice care as only end-of-life care. And some would even quantify it as the estimated last 6 months of life. But I want to say that this difference exists only in the US. Only in the US that there is a difference here.
Okay.
Unfortunately, a lot of our websites are actually American websites. So, the information tends to get perpetuated. Why does this difference exist? You need to understand. In the US, generally healthcare is sort of like a private healthcare system. Patients either pay out of pocket or they're insured. But hospice care, if a physician can sort of certify that to his or her best medical judgment, this patient is at the last 6 months of life, then patients qualify for a federally funded insurance program, meaning the government pays for it.
Right.
And so the distinction is important for the US because of a funding issue.
Yep.
But elsewhere in the whole world, actually palliative care and hospice are essentially the same. They refer to the same type of care, which is the focus on quality of life for patients with life-limiting illnesses. However, in the Malaysian context, I think unofficially, whenever we talk about hospice, it really refers to the palliative care service providers that are within the community.
Right. And I think that's kind of a very important distinction that you're making for us, Doctor. So in the Malaysian setting, really, I think that means there's no significant difference between palliative care and hospice care.
Yeah, right.
Right. But generally, you'd still find most of your palliative care physicians operating out of a hospital setting as well as providing like at-home, like community services. Is that true, Doctor?
I think if you're talking about palliative care doctors trained within the Ministry of Health, it's all within hospital system, you're right. There are doctors who are working in hospices, which are palliative care organizations in the community. But I think hospices have kind of come up on their own,
right,
in a very unofficial manner, sort of, if you're interested to know, actually palliative care development in Malaysia actually started with the hospices.
Right.
In terms of the numbers, I think offhand, I think you're right in the sense that there's still a higher concentration of palliative care doctors within the hospitals.
Right.
But hospices, function not just with doctors, but they have a really good, number of nurses working with them as well.
Okay. Yes, of course. Of course, because I think as you were saying, I come back to that triangle that you were giving us earlier, right at the beginning. And, just to kind of share with everyone again about that palliative care is not just, I sort out the pain or I sort out this symptom. There's a lot of, as doctor was saying, Exactly. So there's the other part of the triangle, which is the psychosocial, spiritual kind of angle, as well as the advanced care planning. So a lot of this is a lot of people involved together. So it's a palliative care team, isn't it, Doctor?
Yep, absolutely.
Right.
I think if you're talking about palliative care delivery in other countries, I'm talking about developed countries like the US, the UK, even in Australia, the palliative care team is actually a multidisciplinary team. So consisting not just of doctors and nurses, but social workers, chaplains, depending where you are, there may be psychologists as
Right.
part of the team,
Right.
other sort of therapists to give a really holistic kind of care to the patient. I think right now in Malaysia, we try to do the same, but oftentimes it's just the doctors and the nurses, and we have to wear all the hats, social
Right.
worker hat,
Right.
the chaplain hat, and all
Right.
sorts of hats. Yeah.
Right. And maybe I think since we're on this as well, probably now's the kind of good time to ask. So in Malaysia, how do you get to palliative care? Because we spent quite a bit of the early part of this discussion telling to patients that, look, we need you need to, if you're coming in with advanced cancer, I think the idea is to access palliative care as soon as possible. Now, just to understand, doctor, if you are within the Ministry of Health, and let's say you're being seen like in a government hospital, is it going to be that where, let's say, and I know this is very, how to say, black and white, which is not really the case in many cases. So should it be if I'm in stage 3 and then I get diagnosed with stage 3 cancer, I should immediately make sure that, as part of my treatment, I should be referred to a palliative care physician. Is that true? Is this false? I no idea. Just
Okay, Dr. Morelli, I think before I answer that question, if I may, I'll just take a step back. Why is palliative care important for those with advanced cancer?
okay, yeah, sure. I think that's kind of important as well. Sure, doctor,
Hang on,
because
let me
you
try
were
and
telling us
share the slide again.
for sure. You were telling us about this a little bit earlier.
Okay. Oh, do you see my slide?
Not yet, but I think it should be popping up. There you go.
Okay.
Okay.
If we're talking about advanced cancer, especially, patients actually have a lot of symptoms. Pain, breathlessness, nausea, vomiting, reduced appetite or lack of appetite, weakness, fatigue, depression, anxiety. Majority of patients actually would have some of these symptoms. Why is it important to refer to palliative care? Is really focusing on trying to relieve some of these symptoms to reduce suffering. Pain is highlighted because from previous studies, we know that of cancer patients, at least 50% of them will have some degree of cancer pain. And if we are looking at advanced cancers, the number goes up to 3/4. So almost 75% of patients with advanced cancer have cancer pain. And as we had talked about earlier, unfortunately in Malaysia, most cancers are diagnosed, majority of them are diagnosed in advanced stage. So that kind of gives you a sense of how much pain is out there, how much cancer pain is out there. Of course, the oncologists and other doctors can also treat some of this pain, but actually, I think the best persons in terms of focusing on the holistic management of symptoms would still be the palliative care provider. So your question as to when would be a time to refer to palliative care, if you go back to the earlier graph, where, at the start of diagnosis,
Yes.
right? But I think more importantly, especially if patients are having symptoms.
Right.
If you or your loved one suffer from cancer and you're having pain, breathlessness, nausea, vomiting, and that's not well controlled by your primary doctor, that would be the time to prompt your doctor to try to get hold of a palliative care doctor.
Right.
And if your doctor is unaware, you can help to educate them as well. You had asked me how to access palliative care in Malaysia. Most state and major specialist hospitals in Malaysia would have some degree of palliative care. Of course, different hospitals will have different levels of palliative care provision, but at least major hospitals would have somebody who could do some degree of palliative care.
Right.
Out of the hospitals, Ministry of Health hospitals in Malaysia, as of this point, 7 actually have resident palliative care consultants, meaning the palliative care team is actually based within the hospital.
Okay.
And these are Ministry of Health hospitals.
Right.
So like starting from the north, Penang, Alostar, Sultanabaya.
Sorry, doctor, we had a slide on this, right?
Yes.
I remember seeing one.
Okay.
This somewhere. Yeah.
It's quite a busy slide, but
okay.
we can try to take a look here. Okay, so I'm not sure if you can make it out, but so we have palliative care within the hospital in Alostar, in Penang,
Okay.
In Ipoh,
Right.
HKL, IKN, Hospital Selayang, HDAR in Klang, and most recently Seremban Hospital. And on top of that, you have palliative care resident consultants at university hospitals as well, University of Malaya, and then UITM. And the rest, may have a visiting palliative care specialist.
Okay.
Or they may not have a palliative care specialist per se, but they have medical officers doing some degree of palliative care.
Got it.
Okay, and then on top of that, there's also in the private sector, there are a handful of private hospitals that offer palliative care.
Right. Right. So, coming to both sectors. So, doctor, let's say you are in an area in which there is like how do sorry, I'm just going to backtrack and ask. So, how do the NGOs, kind of the hospice societies that you can see on this slide as well, how do they come into the picture? How do you end up with them if you're already with a government hospital, or you're with a private hospital where there seems to be in hospitals like yourselves where there's already palliative care physicians? How do the hospice societies or NGOs come into the picture?
I think we work together because if you look at the patient journey, if the patients are able to come to the hospital, they can see us. But, patients are not going to be in hospital all the time.
Okay.
They'll be going back to their homes.
Okay.
And for some patients, they may come to a point where they're too weak to comfortably journey back to the hospital.
Right.
And so we work very closely together with the community providers, the hospices. Patients who come to the hospital and see us, we may start them on certain pain medicines. And once the symptoms are controlled, patients are discharged home, and we will get the hospices to come and visit with the patient to ensure that symptoms remain well controlled even at home. And if for any reason a patient can't cope at home and needs another hospital admission, hospices will again communicate back to us, and we can get the patients admitted. So we work very well together, actually. Unfortunately, I must say that there are a lot of hospices and palliative care providers within the Klang Valley, but outside of the Klang Valley, unfortunately, there are areas that are not covered by hospice organizations.
Right.
And, I'm also part of the National Palliative Care Development Technical Committee. And what we're hoping for, with time over the next 10 years, to be able to increase palliative care service provision, especially in the smaller towns, away from the big cities.
The big cities.
But you can imagine, it's not something that can be achieved in the short term, but there are plans to expand.
Right. Okay. I'm sorry, doctor. This is maybe a bit kind of routine, but sometimes we get a lot of patient queries about this. So let's say I'm just modeling out even a patient we had last week. So patient was originally treated in Kuala Lumpur and then discharged back home to Ipoh. So and then at that point in time, do the patients get in touch with the hospice themselves in Ipoh, or do they go to Ipoh Hospital and then get in touch with the people in Ipoh Hospital palliative care? I'm sorry, may seem like a very routine question.
Sure, I'm happy to
Yeah.
answer that.
Mm.
It depends. I think if the patient is going back to Ipoh but would come back to KL for further treatment
Mhm.
and is otherwise still well, what we might do is link the patient up with the hospice organization in Ipoh, in which case is the Perak Palliative Care
Mhm.
Society,
Mhm.
PPCS. Usually hospices, the way to get linked up with hospices is not by walking in and knocking on their doors. Usually a doctor needs to make the referral.
Right.
So if we know the patient in KL, what we'll do is we'll make a referral to PPCS in Ipoh,
Mhm.
and then PPCS will actually contact the patient and family to arrange for a home visit. Why I mentioned about whether the patient was coming back to KL or not is
Mhm.
because if say the patient has already completed treatment or is no longer fit for treatment in KL and has no plans to return back to KL, there's actually a consultant palliative care provider in Ipoh General Hospital.
Right.
And we would actually formally refer the patient to her in addition to PPCS. So then there is community coverage, but at the same time, if the patient needs to go back to the hospital, there is a hospital, much closer to her, and there's a palliative care consultant there who can actually attend to the needs.
Right. And perhaps this is a really horrible thing to bring up, but unfortunately, it's quite a reality as well. What do you think, doctor, in terms of, I mean, and again, these are patients that are of problems that we face with patients, sometimes in people who are ill long term, even with chronic cancer, there's often is there abuse of the palliative care system? Like, okay, somewhere near Diwali, everyone wants to admit the the, the patients in their house and go off and have a holiday. Are these real? I mean, have you seen problems like this?
Um, well, I think abuse is a very harsh word, but I think fundamentally it's not easy caring for a patient who is that ill. The caregiving needs are actually really high, and family members, especially if they don't have a high number of them to kind of rotate, and it always falls back down to the one or the two persons, they can get burnt out. They can get really tired. It may actually affect their own health, physical health as well as mental health. So some of the palliative care units, we actually provide what we call respite services, meaning it's pre-arranged. That means it can't be, an urgent admission, but it's pre-arranged depending on bed availability, and arranged admission of the patient, perhaps for a few days, perhaps up to a week, to give the caregivers a break.
Right.
And I think in government hospitals, beds sometimes are quite tight.
Mhm.
The bed situation is quite tight.
Right.
So of course, it has to be pending bed availability. But these sort of things can be arranged ahead of time. Preferably, uh, it can happen around festive occasions as well. But sometimes if everybody is wanting that over the festive period, then it's going to be tough on the beds as well. So
Right.
it can be arranged.
Right. So I think an important point that maybe doctor is kind of putting forward is the idea of respite care. So it's not that, I think Dr. Karen has been very kind of objective on that to explain that it's not that we're worried about, we don't care about caregivers or we don't understand about caregiver burnout and caregiver fatigue, but I think the idea of having that discussion, planning for respite care, and then using the resources available, because really the resources are available, because and I'm sure all of us have these kind of situations that we've dealt with where patients end up in the ED and then they just kind of parked there, and then sometimes even with caregivers or families going missing and coming back weeks later, much to the sorrow of everybody involved, not of course accepting the patient. Right. Doctor, I just also perhaps wanted to kind of draw a little bit of info because from you on this, the Malaysian Hospice Council, because that entity exists. Yeah. There's kind of a grouping together of everyone.
Yes. So actually, hospices started services in Malaysia way before, Ministry of Health hospitals actually had palliative care. Back in 91, I think it started off with Hospice Malaysia, and then at that time the Penang Cancer Society started offering some home care services, also the concept of hospice.
Yep.
And over the years, to date, it's a rough estimate, I can't be exactly sure, but I think there's about 30 hospices within Malaysia. 26 of which are registered under the Malaysian Hospice Council. So MHC is actually an umbrella body representing the hospices. Hospices in Malaysia, they are NGOs, so they're independent. Even if you hear the name Hospice Malaysia doesn't govern the other hospices. They are all independent of each other.
Right.
And the majority of them are actually registered within the MHC. So MHC then becomes the voice for the hospices.
Hospices. Okay.
Yeah.
Okay. Got it. Just to kind of clarify like that, so that it's not like you call Malaysian Hospice Council and then they refer you to the local hospices in case you actually need the hospice service to be provided. Yeah. Also, doctor, I think as part of this entire discussion, I think you have been talking to us about how palliative care is really about the holistic provision of care. So, but is it really effective in the sense that is there clinical evidence is the question perhaps to ask. Is this really of benefit to the patient, or is this about making them feel better?
Thank you for asking that question. I think that's an important one as well. Oftentimes people think about palliative care as TLC, tender loving care. So people don't think so much about whether it really works. But actually, I'm very pleased to share with you this slide. I'm sorry, I'm a bit slow with the slides here.
Oh, no problem, no worry at all.
But we know actually there's evidence to show, really good evidence to show that palliative care actually makes a difference. There's, in fact, I just want to kind of point you to a landmark paper that came out of Boston. So this lead author, lead investigator, Jennifer Timmel, from the Boston, Massachusetts General Hospital, which is a teaching hospital of Harvard, actually published a paper back in 2010 in the New England Journal of Medicine, where she looked at patients who were newly diagnosed with non-small cell lung cancer, and they were randomized to two different groups. One group was to receive standard, so normal, regular oncologic management, and the second group would again continue with the regular oncologic management, but also would be referred to a palliative care provider early on. So within a short period of diagnosis. And what the palliative care provider would do is meet with the patient at least once a month, to check on the symptoms and how the patients were coping. And what she found at the end of the 3 months was that the patients who received palliative care had better quality of life, had reduced depression,
Right.
were able to kind of cope better. And what was an unexpected finding of a study was that the patients who received palliative care ended up having a slight improvement of their survival as well.
Right.
So, and this study was kind of, since then there's been more studies looking at early palliative care, and they were all similarly showing the results, better quality of life, reduced depression, better coping, less aggressive care at the end of life. So where patients are dying, they get CPR or even chemotherapy at the last few days. So patients who receive early palliative care actually had less of those aggressive care. And what's important to note is that, although the Timmel study was quite surprising in the sense that, as a palliative care provider, my focus is more about quality of life. We don't expect palliative care to actually extend survival.
Right.
But she showed that patients actually benefited from a survival standpoint. And this goes to show that, if anything, palliative care doesn't shorten life.
Right.
So I think that's an important concept, especially when we are trying to encourage doctors to refer to us or to get patients and families more accepting of palliative care. Is that, we know it doesn't shorten life, but what it can do is optimize the quality of life. So since the Timel paper came out, there's been more studies to kind of prove that early palliative care helps the patient, so much so that actually professional organizations have come up in support of palliative care. Early palliative care referral, the American Society of Clinical Oncology, European Society for Medical Oncology, and the WHO in their World Health Assembly back in 2014 even stated palliative care is fundamental to improving the quality of life, well-being, comfort, and human dignity for individuals. And they actually kind of sought to encourage governments to try to incorporate and integrate palliative care into the healthcare systems in terms of providing a comprehensive healthcare.
Right, right. And I think even if nothing is comes out of this evening, right? I think the most important point that maybe Dr. Karen made is the fact that, look, there's very clear clinical evidence to kind of point out, like, bringing in the palliative care physician into the entire kind of treatment process and the treatment management not only allows people to live better with the disease, it allows them to live longer as well. And if
That's true, Dr. Murali, but I just want to say the caveat here is that not all centers are able to provide the degree of palliative care that was provided at the Massachusetts General Hospital, because that's
Sure.
pretty sophisticated level
Yeah.
support. But I
Right.
think the emphasis in palliative care is always about quality of life.
Right, right. So because as you know, Malaysians like this buy one free one. So if this isn't enough to make a case that quality of life, which really is the most important fact, there's this nice kind of added benefit that you seem to be getting in signal from the evidence as well. Right now, Doctor, just as we're coming up to the tail end of the session today, I wanted to ask you about really this big issue pertaining to palliative care. Even for me, there's a huge number of patients who are very resistant to palliative care and pain management. And really, this is because of I always use this term ajaran sesat pertaining to how they feel that it's about pain, opioid addiction. You're going to overdose these patients. They're going to get addicted to your pain medication, including morphine or however. How much of this is real? How much of this is not?
I think there's definitely a lot of reluctance among Malaysians about the use of morphine. And I think this probably speaks of the success years ago when the government was, going against, campaign anti-dada and all that. Morphine is associated with drug addiction. But actually the reality is, if you're talking about drug addiction, that's a different concept altogether. When we are using morphine, we're using it for pain. There is, I would say that there's no risk of actually, or we would say very, almost nil risk of getting to a state of addiction, just because when we are using morphine, we're titrating it to the patient's pain. When talking about drug addiction, drug addicts, usually they're abusing drugs in the sense that there is no pain and they're taking medications to get the high, the euphoria associated with it. When we use morphine for pain, there's no risk of going into addiction because we are titrating it to the patient's pain. And this is a very important thing to know, because oftentimes families are resistant to doctors giving morphine to their loved ones for cancer pain. And that's actually really sad, because for the patients, being free from pain is usually the number one most important thing. Because when they are in pain, they can't sleep, they can't get around with their daily activities, they can't eat. I've had patients who are begging us to end their lives because they were in so much pain. So from the patient's perspective, I think pain relief is actually the priority. And there's no concern for addiction when we're using morphine for cancer pain. I think along those lines, oftentimes people worry that morphine will actually damage their organs. They will ask if morphine will actually harm their kidneys or liver. Morphine doesn't do that. of course, when a patient already has a weak liver or weak kidney, impaired liver or kidney, we have to be more careful with the medicines that we're giving. But morphine itself does not cause any of these damages.
Right, right. And I think along with this, I think almost not unnatural, but this very unfair expectation that cancer patients have to just bear the pain. Have you faced this issue as well, doctor?
Yes, I've encountered it where
Yeah.
patients, or rather, I think mainly perhaps our family members think
Mm,
that it's expected, it's normal, but that is so far from the truth.
right.
Although pain is common in cancer, it is not normal. It can
Yep.
be treated,
Yep.
and in this day and age where morphine is readily available, I think it's actually cruel to leave a patient in pain and
Yep.
not treat it adequately. Of course, if we were in a country where morphine is difficult to access, it would be a different story. But in
Right.
Malaysia, actually, it's readily accessible, of course, by healthcare providers in the hospitals. So on that note, I don't think it's a fair assumption to make that cancer equals pain, that dying equals pain. There is
Right.
so much we can do to relieve the pain.
Yep, and really, there's even this weird set of thoughts or beliefs around people. Some of even my own patients, I've got two or three of them who believe that if you treat the pain, it's actually helping the cancer grow or
Oh,
worsening
that's
the cancer.
not
Yeah,
true, not
yeah,
true at
yeah,
all.
exactly. So really, I don't. I really think that Dr. Karin is telling us again and again this thing that look, the pain is part of the cancer, but it doesn't mean you need to suffer with the pain, right? And that's really
Absolutely.
the role of the palliative care physician to make sure that they can manage that pain, which is one of the biggest symptoms. Coming back to this kind of reaffirming, doctor, I think we've spent the whole session talking about this, but this is also, I think, remains one of the largest myths, that you only refer a dying patient to a palliative care physician. And although you've talked about this to depth, would you kindly tell this again?
I love
And
your pun.
yeah,
Yeah. So
yeah,
I think just to reiterate again, palliative care is not just about end of life care. It's not. It's not. Uh, it doesn't mean when your doctor refers you to palliative care, it doesn't mean the doctor has given up. And palliative care does not mean nothing will be done. So these are common myths that I've listed out. In fact, palliative care, if anything, to me is very active care because we are actively looking at the holistic management of the patient to ensure that they are comfortable. Another myth that we talked about was pain is normal and expected. It's not. It can be treated. And morphine equals dying or will damage organ and lead to addiction. These are all false. They are myths, not grounded in truth at all.
right, right. And really, I hope we've done quite a bit in kind of hacking away at some of these weirder ideas. Hopefully, Doctor, we start to see. And it's sad to think that even this is a culture, I think, which I say sometimes it's with healthcare professionals as well. This thought that we need to die trying. That's the culture. I think you spoke about it. What is this earlier? That we ingrained into us is this idea that we have to try until the very end. And I would actually, I think you have made the case for it as well, that the trying actually includes the palliative care physician, rather than
Absolutely.
yeah, you finish trying and then only you bring yeah, the palliative care team in. So, doctor, I'm so sorry. I know we could end up talking this the whole night, and that's always been a problem of mine. I hate that these sessions have to kind of come to an end. So, as we kind of wrap up the session, are there things that you might want to share with us, to leave us with, to kind of hammer into our minds?
Okay, I think in addition to what I've already mentioned, I would really encourage our viewers, if you think somebody could benefit from palliative care, don't wait for your doctor to make that referral. You can advocate for the person yourself. So I hope that my talk managed to clear up some questions about palliative care. Again, to hit it home, palliative care is not just about death and dying. It's about the active holistic management of a patient throughout the cancer journey. The referral timing actually really depends. It can be early at the time of diagnosis of advanced cancer, but I would say especially if the patient is having symptoms, patients having pain, shortness of breath, that's not controlled, that will be a good time to get hold of a palliative care provider. And how? If we talked about the service being available in public and private hospitals as well as hospices, I would encourage you to also refer to the Malaysian Hospice Council website. They have links to providers depending on areas. Different states will have different hospices. At least there are some contact details there. You can actually try to get a hold of the hospice organizations there. And most major state and major specialist hospitals within KKM would have some degree of palliative care. You just have to find out how to get a hold of them.
Right. Right. So really, it's been a very, very important session, ladies and gentlemen. So if you recall, we started off with this entire the Lung Cancer Network Malaysia and National Cancer Society Malaysia's kind of journey in kind of looking at these various aspects of lung cancer. The sad reality is, as much as this campaign is about pushing people to get diagnosed early, more than 90% of our patients with lung cancer especially are the ones turning up in the latest of late stages. So for those who are coming in this advanced stages of disease, look, you need to kind of, this session is about opening up the options available to you. So you need to be able to consider palliative care as part of that treatment process from the moment of diagnosis. And Dr. Karine has kind of wrapped up nicely for us today. What is it that palliative care is about, and what is it that the value that the palliative care physician, the palliative care team kind of offers in terms of the treatment journey. So I'm just going to, I think we can, are you okay, doctor, to take a few questions if we have? I have kind of taken a few questions off and on from the Facebook, and I'm just seeing if there's any other questions. Are you okay to take one or two still? Sure. Lovely, doctor. Let me just see if there's questions on the Facebook. There's one on, there's a comment really from a viewer on there should be a national palliative policy in Malaysia. There is just not enough. People in rural areas also need it. But you've kind of spoken about how the government is taking a little bit more affirmative action to ensure this is happening, doctor.
Yes, in fact, we launched the National Palliative Care Policy and Strategic Plans last year. The plans are supposed to encompass 2019 up to 2030. So it lists down, several aspects of expansion plans actually. So thank you for that comment, and I would like to say that there are plans actually. But I think because with the COVID, outbreak and things were sort of delayed for a bit, but the plans were actually, the policy was actually launched November 2019 by our then YBMK, our health minister at Hospital Selayang.
Right, I remember I was there at it as well, and I think the important thing is to figure out that this is an ongoing process, and we're inching slowly towards improving. So the current, I think one of the interesting things that you've pointed out for today is the fact that how both the public hospitals, the private hospitals, and the community organizations are all kind of working together in provision of care. So really, if you are a patient or you are a caregiver or you have someone in the family who has cancer and you think they could benefit from a palliative care kind of input into their treatment process, please don't hesitate to reach out. There are multiple channels, and as Dr. Karine has nicely kind of put on the slide, that's the address of the Malaysian Hospice Council. You can go on to that and kind of get onto that as well. Any kind of last words for us, doctor? Oh my God, that's not a pun. Sorry.
I would say palliative care is everybody's business.
Yeah.
It's not just for those who have life-limiting illnesses. But if you think about it, it's important to invest in palliative care because eventually our day will come.
Right.
So for the community members, how you can actually contribute would be if you can look around within your region, if there are hospice organizations, and if you can contact them to see if there are things that they may need. I think hospice organizations generally run on donor funds. They are charitable organizations. So as a member of society, there are ways you can contribute as an individual as well.
Right.
Palliative care is really everybody's business.
Right. So, and really on that note, we'd really like to thank you, Doctor, for taking the time again this evening to join us, and hope it's been as wonderful a session as it has been for me and for our viewers as it has been for you. And ladies and gentlemen, so if your teh tarik sudah habis, time to get that second glass of teh tarik. No lah, it's time to wrap up, to go to bed. Thank you very much for being on the sessions. As always, you can find both this session on the YouTube, on the Facebook pages of both our organizations, Lung Cancer Network Malaysia and National Cancer Society Malaysia. Thank you very much, and good night.
Thank you very much for the opportunity to share.
Okay, goodbye.
Good night.